Well, terrific, everyone. Good afternoon and welcome to the Epilepsy Research UK More Than Seizures webinar. I'm Dr. James Pickett. I'm the Head of Research and Innovation at ERUK, and it's my pleasure to compare this afternoon and to invite you all to this webinar. So we've got a really exciting packed hour for us, and I hope you can join us for the next hour. So just very quickly before we get into it, just who Epilepsy Research UK are. We're the only charity uniquely focused on epilepsy research. And really, we're aiming for a life free from epilepsy, and we believe through research that can be achieved. And we do this really through the majority of our activity through funding research across UK hospitals and universities that we think will make the most difference to people living with epilepsy in changing their lives. We've got several priorities in what we're doing that you can see on the screen here. Firstly, to fund the best research we can find, but also to develop the next generation of epilepsy researchers, and also to accelerate kind of the implementation and the transfer of the knowledge that's generated in research so that it does make difference to people living with epilepsy. And we're really pleased to say that even during these current times, we have current funding calls out to fund fellowships and doing some joint work with another epilepsy charity, Young Epilepsy, and also working in the innovation space to understand how health is changing due to COVID and the effects of that and things that we want to see going forward in the delivery of healthcare. We're delighted to do some of that with Epilepsy Action. So quickly on to today, I'm really delighted we've got 4 really great speakers that we're going to hear from over the next hour. And what brings these all together is the theme of today being change makers, that their research has all, as well as being published in the best journals and generating the information, has really gone above and beyond that and is changing healthcare practice and policy around epilepsy. And just a quick plug here, but all our speakers have all written within the last month for our epilepsy blog, which you can read every Wednesday on our website. And I think if you look in the chat, there's a place where you can click through and sign up to receive this. But we endeavour to publish a new, interesting kind of prospect from research every week. And I really encourage you to have a look at that if you can. So that's enough of an introduction from me. And enough plugs, but I'm absolutely delighted to introduce our first speaker, Ngawai, who's going to tell us from her personal experience about epilepsy and what research means to you. So I'll hand it over to Ngawai. Thank you, and I hope everyone enjoys this afternoon.
Oh, hello. Hi, everyone. My name is Ngawai Moss, and thank you very much for inviting me to speak today. So I have epilepsy, and I just want to tell you a bit about my journey and how it links in with research as well. So I was diagnosed when I was 11 years old, and I had my first tonic-clonic seizure. But from that, my seizures have been reasonably well controlled. And at the time, my GP and neurologist were drilled into me that if I ever wanted to have children, I had to have my medication reviewed. So I was very lucky, but even from a young age, that really hit home. So when I wanted to start having a family, that's the first time really that I noticed that epilepsy was an issue for me. Previously, even though I'd had seizures, they were few and far between and I could just get on. But the process of trying to get pregnant and how I managed my medications really highlighted how much of an impact epilepsy had. And this is at this point that I actually first got involved with research. So I was very lucky when I did go and seek advice and review of my situation to try and get pregnant. I was lucky that I went to a research active hospital, and my epilepsy research nurse was also research active. So I was very lucky in that response, in that regard. And so they offered me the opportunity to take part in a piece of research around anti-epileptic drug monitoring in pregnancy. And I decided to take part, and I did that for 2 reasons, really. One was a personal reason. So having considered the benefits and the risks of the research, I decided that I did want to take part because actually I would be very closely monitored. And that's something that I really appreciated. I had really good experts and a multidisciplinary team, and I had regular appointments. So that was really reassuring element of the research. And the other reason I wanted to take part was because it was a difficult sort of experience. You know, living with epilepsy and pregnancy, it was quite a different state, really. And I thought that actually taking part in research is something that I could do that adds value. So I'm going to be pregnant anyway. So actually to be able to offer something to women later on in life, to other generations and my future daughter, you know, you feel like that's actually something really important. So they're the reasons why I got involved with research. And I think for me, the research offered me also a couple of things. So it meant that I felt really empowered. So I was better informed about my epilepsy, and I was better informed about how it works when I'm pregnant. But also it really helped me when I went for my second pregnancy, because I felt I was more in control and I knew about what to expect. And it also gave me confidence to actively manage my condition. So I think that's what taking part in the research offered me. And I think, to me, it just kind of, looking back now and reflecting on that experience and reflecting on other work that I've done in research, it made me sort of think about what research actually, or consider what research actually means. And I think that we can really generate transformational change on how we manage our conditions through research. And that could be epilepsy, but a whole range of other things as well. So I think that's the power of the research, that it actually can really transform how we live. And also, it's not just about, the research isn't just about us and improving you know, our experience of living with epilepsy, but it's also for everyone around us. So it's our families, it's the carers that help us, it's the network of people around us that support us, and you know, it's for them as well, and they're equally a part of our journey in our experience. So I feel like that's something not to be overlooked. And I think, considering what research means as well, it's not just about the UK, but research actually really has a global impact. And I think you know, if we reflect on all the COVID work, just kind of, you can see that any meaningful findings that have come through from research can quickly change practice across borders. So that's something else to consider, that the research that we help enable, or that we take part and participate in, can have really knock-on effects much wider than just ourselves or our local or national community, but further afield. So I think that just highlights that that's the potential impact of research, really. So I think that's just a bit of an outline about my experience. I feel very blessed and lucky to be in this position, and yeah, I hope it provides some insight into epilepsy research and research in general.
Wonderful, thank you so much, Ngawai. We have a time for some questions, and I forgot to introduce, we have activated the chat function for all the attendees, so do feel free to use that if you'd like to make any comments as we're going through. But we've collected some questions in advance as people registered, and my colleague Quiva is actually going to manage that part for me. So I'll hand over to you, Quiva.
Hi, thank you so much, Ngawai. That was really, really fascinating. I loved what you were talking about in terms of the impact of epilepsy, not just on you as an individual, but on your family and people around you. I think a lot of people watching this will really resonate with that. So thank you so much. And obviously you spoke about the potential of research to generate transformational global change. And I think that's really interesting. And so to build on that, what are your hopes for the future of research into epilepsy?
Yeah, so I think that's a big one. So I think the most obvious is kind of part of your objectives, what you said, a life free from epilepsy. That would be the ideal, really, or at least the ability to live with no seizures. I think that's what we should be aiming for. But I think right now, what we can actually do is to ensure that the research that we do is relevant. So it's relevant to patients and carers and our networks, but also that it's the best it can be. So I think patients can actually shape the research. So they don't just have to be participants in research studies, but they can also be part of the team that generates the research. So we can have a role in the whole life cycle of the research. So right from the start, when we're thinking about developing a research question or thinking about what's important to be researched, considering the design of any study and how that actually applies in the real world. So I think that's one area. Patients can also help secure funding to help pay for the research to take place, and that could be by providing input at the beginning, in developing the question or the study, but also as being co-applicants on research. So when the researchers go to get funding, patients can be part of the team to enable that. And they can also help shape the study of the design, because the way that a study takes place in real life, and you're asking people to participate in the research, well, actually, if you have the condition you understand, or if you're, not just you, but the network around you, you understand what's required and what's practical, what's not practical. So helping to set it up, and in essence becoming partners alongside the researchers, ensuring the study is well managed as well. So sometimes in these studies you have an oversight committee, you can be part of a committee, and maybe help interpret the results as well. I think also something that's really important is helping to share the research findings, because to do any of this work, it's like a monumental effort. That's the one thing from my experience that I started to really appreciate. It's really a monumental effort to get the research up and running, and actually to do it. And I think it's only right that we help share the results and ensure that the results actually translate into practice and they change practice. And there's ways we can do that. So, everyone's situation is different, but you can actively, one of the things I did with my epilepsy in a study was that when the findings came out, I helped to communicate those to my local clinical commissioning group. So they're the people that commission services in our local area, and to try and raise the profile that this is actually an important thing they need to be considering when they plan. That work actually led to the development of national guidelines in how epilepsy is managed in pregnancy from the Royal College of Obstetricians and Gynecologists. And for future research, that study also helped develop what they call core outcomes. So making sure that in future, any research in future in pregnancy with epilepsy, they capture the same, a certain number of information that is the same, so that you can compare. So they're just some of the things, but we can also support. So that could be sharing, resharing research studies on Twitter or Facebook, raising the profile. So there's all different things we can do. But yeah, I think we need to consider that it's important that the research actually applies and has an impact on the ground, and that's really important.
Thank you so much, Ngawai. I think that's particularly relevant to some of the speakers that we have today, and the change makers, and our speakers have all worked with people affected by epilepsy in in different ways as well. So I think that's the only question we have time for. So I'm going to pass back to my colleague James, but thanks so much, Ngawai.
Thank you.
Yeah, to me, to you, it's a right double act, isn't it? But it's a real pleasure to introduce Dr. Rebecca Bromley next, who is from the University of Manchester, where she's a clinical psychologist and a research fellow, and she's going to tell us about her work over many years looking into pregnancy and epilepsy. So delighted to have you with us, Rebecca, and I'll hand over to you.
Thank you. Good afternoon, everybody. I'm coming live to you from my kitchen. I'm going to really follow on quite nicely from Ngawai, really, and talk about the work that we've done surrounding medication use for women with epilepsy. And I guess just kind of to start off with that, you know, I'm representing a group of people that have worked on this. I don't think any research endeavour is ever done in isolation by one person, and that includes researchers and clinicians, but also patient involvement, as Ngawai has highlighted so beautifully. So every good piece of research starts with a problem that you want to solve, and a very clear problem for the group that I'm representing is that there was a situation where there was an unknown understanding of the risks that may be associated with certain medications if they cross the placenta while a woman was pregnant. And so therefore helping women plan a pregnancy was incredibly difficult when talking about the benefits of the medication versus the risk. And this is problematic for two reasons, really. Number one, it removes the confidence that the woman with epilepsy has around choosing her medicine and feeling confident in that choice and using her medicine correctly. We do know that, you know, lacking in confidence tends to lead to women stopping their medicine or reducing their dose when they find out they're pregnant. And actually having clear guidance and support, you know, reduces that need and makes women feel confident in those medication choices. The second situation that leads from the problem of uncertainty and lack of knowledge is that if we did have a risky medication that was in use, we would end up with a situation where more children than required were exposed to that medication than necessary. And therefore, ourselves and other researchers around the world set out to try and understand the different risk and benefit profiles of each of the individual medicines. How did we do this? Well, it's not the easiest thing to do, but we like a challenge. So we tend in our research to recruit women from hospitals in the UK, sometimes internationally, depending on the project. And we recruit women during pregnancy because that limits some biases that can come from recruiting families once the child has been born and they know about the developmental outcome of the child. We then do assessments with the children when they're babies, and then if we've got the money, we follow them up into childhood to really watch how those children grow and change. And those of you that have had any experience with children, whether that be your own children or that are friends or family members, you know that that kind of period of development, it kind of really 0 to 10 years of age is really quite rapid and staggering. And so we like to follow children up as long as we can to make the best conclusions. So when we've got these this cohort of women that are pregnant and then they have their babies and we're following their babies up, how do we collect our information? To give you a little bit of background and insight into what we do. Well, we take the information when the mother's pregnant. We find that out from speaking directly to her. I'm a great believer in that we get the best information when we go directly to patients. We may well use medical records around their medication, find out a little bit about birth history, etc. But then also we then directly follow and review the child throughout their early years. And now in babies, this is often a play-based assessment, which involves toys, and you give them little tasks to do with those toys, and you mark how well they do that task for that age. And then in children, as they get a little bit older, we tend to do more formal assessments with our preschool and school-age children to find out things about how well their language is developing, for example, or how good they've become at reasoning tasks. We may well interview their parents about their social skills. And we might, if they are school age, write to their teachers and find out a little bit about how they're getting on in school as well. And then what we do is we compare the children across the different groups, often to a group of children that weren't exposed to medicines in pregnancy. And we look at those differences after we've taken into account other things that influence child development, because as we all know, lots of things influence the outcome of children, not just epilepsy medications. in pregnancy. And so what did we find? Well, our work along with that from colleagues around the world, demonstrated that there was an increased risk of developmental problems in children that were exposed to one particular drug, and that drug was sodium valproate. What we found is that those children were a little bit later on average to reach their key developmental milestones. So for example, learning to talk, learning to walk, and in school age that we found that they may still struggle with language development, fine motor skills, reasoning also may be below children exposed to other medications. But actually it's important to realise that not every child exposed to that drug was affected, it just increased the risk of some difficulties occurring. Importantly, and particularly here in kind of Ngawai's journey, we've also looked at other anti-epileptic drugs next to valproate, and we were able to show that other medicines appear, based on current data, to carry a lower risk to the child in terms of physical birth defects, but also in terms of development. And for example, two that we've spent quite a bit of time looking at recently are lamotrigine and levetiracetam, and they appear to carry less of a risk. And it's important to delineate those that are safe and those that are risky, because actually that allows people to make those informed decisions based on their current clinical need to treat their epilepsy. So this presentation is all about change, and so I was asked to think a little bit about the changes that our research contributed to. And I think really the whole pathway of change for our work starts with the fact that we provided information to women and their doctors to make decisions. You know, as Ngawai shared, she went and she had a consultation with her doctor, and they thought about, you know, they had to maximise her health while minimising the risk to the fetus, and sometimes that can be a tricky balance. But by having that information, it makes women more confident in the medication choices that they make. Following that data being available to women and their prescribers, we saw a decline in the use of valproate, and that was maximised by intervention from the medicine regulators, the European Medicines Agency and the MHRA for the UK, whereby they've really tightened the conditions in which you can use valproate now. That reduction in use of valproate and the regulatory intervention has meant that fewer children are exposed to valproate. And the important thing there is that if the children don't need to be exposed to valproate, that's a good thing, that we can reduce that exposure. And so therefore we've got fewer children that are being born with the physical defects that we can see, but also the developmental problems as well. Our work, and a particularly enjoyable aspect of our work, is we've really been able to develop a recognition of those that have been exposed in the womb and develop an understanding of the sorts of problems that they experience, and actually what treatments and support from NHS, education and social care that they need to maximise their lives. And just recently we had the Cumberledge Review, which was the Independent Medicines and Medical Devices Review, which was initiated by the government under Jeremy Hunt when he was Health Secretary, and that reviewed his whole situation about how and when we knew about certain risks associated with certain medicines, and a real kind of clear stories come out from that review that we need to improve how we do this sort of research, how we communicate it to patients, how we listen to patients when things maybe aren't going right. And also the review also noted that families of children who had been affected needed more support, and we're really pleased that we're going to be able to work with that in our clinic up in Manchester to support families of children and young adults who have been affected. So I think just to finish, I really have to say a huge thank you to Epilepsy Research UK, because it's not an exaggeration to say that this wouldn't have happened without them. So back in I think 1999, our group was struggling to obtain funding, and Epilepsy Research UK gave a pot of money, which really started this one of our really big important cohorts where we were recruiting women during pregnancy, and we followed them up, and that was instrumental really in us being able to identify some of those risks that are presented to some children when they're exposed in the womb. And also, obviously, Epilepsy Research UK cannot provide us with that money without those of you who fundraise tirelessly and donate, and thank you so much. It's really, really important, and we are so incredibly grateful. So thank you very much for your time. I will pass you back to James, and if there are any questions, I'm happy to do my best to answer.
Thank you so much, Rebecca. That was a really great story. I'll just hand over to Grieve in a second. There's one question that's just come in, and it asks what drugs instead of valproate are being used instead at the moment. So which drugs are you seeing that are on the rise in pregnancies?
So that's a really good question. Obviously, the selection of medication for an individual is very much based on their personal circumstances, their medical factors, the type of epilepsy they have, etc. However, most women in the UK tend to be taking lamotrigine or levetiracetam, or a combination of those medicines with another medicine if they need a second or even third medication. The most important thing is, like Kiva said, that you have a conversation with your prescriber before you think about a pregnancy. So part of your planning stage is making sure that you are in the optimum health and that your medicines are as optimized as they can be for your health, but also for potential fetal health.
Fantastic, thank you. Quiva, do you have any other questions for us?
Yeah, thanks so much, Rebecca. It's great to hear about the impact of your work from as far back as the 90s to the present day with the Cumberledge report. Obviously, the report has just been published. Looking to the future, what are your hopes for the next 10 years of research into this area, do you think?
That's a great question. The next 10 years, I mean, I think the Cumberledge Review and my own opinion is that we have to be more proactive at looking at all of our medicines that are currently in use that we don't really have a full data set on and a full understanding about their risks and their benefits, but also creating a system whereby we do this much more quickly. So we don't wait for problems to be noted, that immediately when a new medicine for epilepsy is licensed, that we are undertaking that research to learn as much as we can about it as fast as we can. And so I think I'd like to see more researchers in the area. I think a big challenge that we've got is not many people research this, and so it makes kind of for a slow moving evolution really of the evidence base. And so I'd like to see more people looking at this. I'd like to see a wider and more diverse set of people looking at it from different angles, and also allowing us to follow up children longer. So most of the time our research tends to follow children up to just maybe year 1 or year 2 of school, so kind of 6-7 years of age. What we'd like to be able to do is to follow them further as well. And I think that recognition of how important brain development is right the way through, really kind of up and into and even past the teenage years, is really, really key. And I hope therefore that we get this more automated, wider system of research with more people to carry the load.
Brilliant, thank you. And I believe that you've worked with, there are a number of valproate patient groups, and I believe that you've worked with a number of them. Would you like to talk about that briefly?
Yeah, I've been kind of working with numerous of groups who are, all represent families who have been on a very difficult journey, who have 1 or more children who have been affected by exposure in utero to valproate. And I honestly have to say I've learned an incredible amount from them. We love to have them involved in helping us decide where we go next. And so previously we held a meeting where they identified questions that they wanted answered, and we've tried to therefore kind of build our research on the basis of that. And they are also great at really pushing the impact of our work as well. And so, they're often present with regulators, and they are a great voice really to represent generally people with epilepsy, and the decisions and the weight of the decisions sometimes you have to take about selecting the right medicine, and they are a great voice within that. We also involve throughout the years and the projects we've done, we've collected really, really motivated women who haven't got affected children, but they've been through that system of planning a pregnancy and then a pregnancy, and usually they've been involved in our research, and they now have sort of come on board and they consult and they give us advice. And we it's, as Ngawai said, it's a beautiful relationship really between researchers, clinicians and patients, and I think it's by far the best way to get research done.
That's fantastic, and yeah, it's really, really great to hear. So I think that's all the questions we have time for, but thank you so much, Rebecca.
Thank you.
Thank you. And we see we've just got a question in there. We'll get back to you while the next speaker's on, Julie. But thank you. Do keep sending your questions through. I realise I haven't turned my video on, but you can hear me, I hope. Great, we're perfectly on time, and I'm really delighted to introduce our third speaker, Gash, who trained in medicine at the University of Liverpool and is now working up in Edinburgh, and will share his data with us. So I'll hand over to you, Gash.
Hi, can you hear me now?
Yes, we can. I think I might have just frozen out there for a moment, but yes, we can see you and hear you. So welcome, and thank you for sharing a bit about your research, Gash.
Yes, so thank you for this opportunity to talk through the Scottish epilepsy death study. As mentioned by James, my name is Gashirai Mbizvo, and I'm a neurology registrar at the Walton Centre. But what I'm presenting is my PhD research at the University of Edinburgh, and currently in the 4th year of my PhD, and also doing clinical work at the same time. As I say, this is it's a sort of difficult topic to talk about, but it's an important topic, and I'll go through what we've been going through. I'll go through to the end in terms of pathways to impact. So in terms of changing policy, I think there's no better place to change policy than directly with the policymakers themselves. And in 2019, I was invited to Scottish Parliament to talk through the pathways to which we could identify problems that can and provide solutions through the research that we've been doing. And it's extremely good to see that the politicians are listening, or at least trying to listen. So this was a cross-party group meeting. And as I mentioned here, it was a situation where I kind of was a little bit in shock. I didn't know how I'd ended up in Scottish Parliament with a session put together just to listen to me talk about my research. And so I go back we look, go forward a year later. We were mentioned in the Nature Reviews, and it was a discussion on a recent conference that we had attended, which was the largest conference in neurology history. And so again, a large pathway to impact, an opportunity to talk about the research that we've been doing. So I go back to where I'm from and how I ended up in this situation, because I think sometimes it's helpful to just understand how we get to these, how researchers end up doing the things that they're doing. And I'm from Zimbabwe, and I think a lot of this has been serendipity. I first came along the idea of anything to do with the mind when I went to university, when we moved to the UK, and I was supported by supportive infrastructure insofar as my parents. And I told them I wanted to do psychology, and they're Zimbabwean, and in Zimbabwe you do medicine or you don't do anything. And they were like, "Look, you're doing medicine." And so I ended up, by serendipity, discovering it was neurology that I was quite into at that time. And so that's how I ended up becoming a neurologist. And at one point, my fiance and I thought we'd go traveling. And again, supportive infrastructure. My professor in Liverpool sent me a job advert and said, "Well, would you like to travel to Scotland?" And that's why he provided me with this opportunity for this job, which was the research project. And so I ended up career change into research at that point, and this was in 2016, not knowing much about research. And I trekked to Scotland, and if, like me, when I first arrived there, I knew nothing about Scotland beyond Braveheart and Donald Trump's golf courses, but I quickly got to learning about Scotland, and that it's got 5 million population, and sadly there's nearly 60,000 deaths in Scotland each year, and there's a rich network of administrative data, which is information routinely collected about patients when we use healthcare services. So we as researchers can harvest that information anonymously and look for trends in mortality. We get ethics permission and things to look after the data safely. And this is really the way this project is designed. So it's this thing called big data, and we're looking for trends in disease. But I still wasn't sure exactly how I wanted to answer the questions that we had. And I ended up at a summer school for PhD students. When they spoke, sort of taught us about how to present your research. So one of the things they said is, you just need to package it in a way that people understand. So what is your research question? Why is it important, and how are you going to answer it? So the research question is, what are the rate, causes and risk factors for epilepsy-related death? And what proportion may be avoidable? And to answer, we're doing a Scotland-wide retrospective cohort study to identify rate and causes. and a case control study to identify risk factors. And these are being facilitated by linking all these administrative data sets together. So what does that all mean? Well, it's Scotland-wide, so it's a national study. A cohort study follows people up with a particular condition over time to see when and how a certain outcome happens. So in this particular study, we're looking at mortality. And in a case control study, we look at those who are alive and those who are deceased to see what differences they may be. And so this is in order to try and help by finding ways we can change care for those who are at risk. So the results we have so far, so this was looking back between 2009 and 2016, and we identified that there was just over 2,000 epilepsy-related deaths. And quite surprisingly, nearly 60% of people in this cohort, in the deceased cohort, had had a hospital admission related to seizures or epilepsy. But only a fraction, only 24%, had been seen in a neurology clinic during that same period. So these acute admissions didn't seem to be translating into actual neurology clinic attendances. And we looked at the trend and we saw that mortality was not reducing over this study period. And this is despite advances in medical care. And we looked at what groups were most highly affected. And we see that it was particularly the young group that were the highest risk. So those between ages 16 to 54 were between 2 and 6 times more likely, unfortunately, to pass away than their age-matched counterparts. So, you know, these were things that we looked into. We sort of looked further at the causes. And the one that comes across or is most well known is SUDEP, sudden unexpected death in epilepsy. But as we identified, this was not the only cause of death that was occurring. There were deaths in relation to respiratory causes, which we think, you know, should be something we can do something about with early antibiotics. Seizure-related deaths with relation to cardiac arrests. And again, we think that there may be an association between heart and brain abnormalities that we may be able to tackle, and mental behavioral disorders in relation largely to alcohol. And again, this is maybe something through education and public health policy we may be able to change. And on that proviso, we used methods to identify which particular deaths were potentially avoidable. And it was recently published in The Lancet. As you classify disease by a classification system called the ICD-10 system, various experts at the Office of National Statistics sat down and put together with conditions based on that system are potentially avoidable. And we applied that system to our data set, and using it, we found that nearly 80% of deaths were potentially avoidable. So we took this back. I mean, this is the sort of information we took back and discussed at Scottish Parliament, and we brainstormed on ideas about things we could be doing. And these are some examples of the sorts of things which we think will make a difference going forward. And as I say, I'm in the 4th year finishing the PhD at the moment. And so going forward, I plan to make this my life's work to try and implement these things in future. So talking about epilepsy safety, so to contextualize this, when you, so there is policy at present that if you enter a building, you need a fire safety briefing. You enter an airplane, you need a safety briefing about entering that plane. We can all recite those. And yet we have a condition which is the safety of which is largely dependent on yourself and those, or particularly those around you, being aware of what to do in an emergency. And yet this information is not disseminated. So we think that this is something that we could have. And the briefing could be given at regular occurrences. And you know, these are the types of things that we think could be improved in terms of public health awareness and safety briefings on seizures. Recognizing that people with epilepsy can be stable for a long time, but things can decompensate at times. And at present, there is a rapid access first fit clinic after someone's first seizure. But by and large, the risk of mortality is not as high after a first fit. But what there isn't is a rapid access decompensated epilepsy clinic where somebody who's stable might decompensate and be plugged into a service quickly. And we think that this is something we should provide, because it may be that we're able to do something to improve care at that point to try and reduce some of the later risks associated with decompensated seizures. And particularly, this is an accolade to epilepsy nurses as well, who we know improve outcomes. And this is a service that can be provided through epilepsy services themselves. And in refractory cases, the availability of epilepsy surgery. We know that epilepsy surgery changes outcomes in certain groups. And again, this is a sort of thing that we you know, again, try to channel through our interaction with the Scottish Parliament to see whether there will be avenues within which we could improve this. So these are just some of the examples, and I hope I've walked through my story as to how I've got to that. and how accessible research is. And just echoing Rebecca, this is not possible through the support, without the support of Epilepsy Research UK and patients as well. And you can see that we have a team of people who've helped facilitate this research, neurologists across the country, all of whom, we've come together for this support of this project, which is funded by Epilepsy Research UK. So really, it's just to say thank you to yourselves for supporting us and helping us disseminate this research accordingly. And I welcome any questions.
Brilliant. Thanks so much, Gash. It's great to hear how the work is not just getting published in journals, but really getting all the way to the people that really need to hear it. So terrific. That's fantastic. Quiver, do you have any questions for us?
Yeah, thank you so much, Gash. I thought it was really, really interesting, your comparison between safety briefings on airplanes and how, that would always happen. And I wonder if that could be something in the future. And so the question is, what are your hopes for future research in this area of epilepsy?
Yeah, so I think one of the things I'd like to see, and a lot of this project has largely been dependent on the availability and understanding of information we have around us. And I think it would be great for us to be able to collaborate more. So around the country, it's great that we have a unique opportunity in Scotland to be able to study data and learn lessons from data. But it does become difficult to cross borders to try and link data together. And I think going forward, it would be fantastic if we were able to link data and learn about what's happening in England, learn about what's happening in Wales, using information we already have. And I think that could, that to have information available on a national scale really gives the project power to be able to identify important things, important trends in disease. And I really hope that that's something in future that we'll be able to do.
Yeah, I think that's really interesting. Certainly recent developments in artificial intelligence in relation to data are hopefully soon making that a reality as well. We've had a question from Alistair on Zoom said, should first aid, and I assume first aid in relation to epilepsy as well, be part of the school curriculum, even from primary school? And I wonder what you think about that.
Yeah, I mean, I think in general, first aid, and I think that's a very sort of astute observation to make. And I think if we could be disseminating anything that makes a difference to a high-risk situation from an early stage, so in the same way as people learn how to swim, if this was part of, it's really about talking about safety, isn't it? If this was part of our language to say that, everyone learns how to swim at the same time they learn how to save somebody if they're drowning, at the same time they might learn how to save someone if they're having a seizure. And if we were able to talk about this and normalize it, then I think it would be something where we could make progress in that, and that would be a tangible sort of outcome. So you're quite right. If we could start to disseminate it amongst schools and have children talking about these as normal things, it would be a good forward step.
Thank you, and thank you, Alistair, for that question. And I know from speaking with you, you've been working on the front line recently with people with epilepsy. How has that been?
Yes, I think these are sad times that we're going through with COVID and things, and it's been difficult, I think, because as you say, things are different. So people are anxious about personal protective equipment, and one of the things I've noticed is people have been anxious about coming into hospital as well. And at times has meant that people who would have otherwise come sooner perhaps haven't. One of the things that we've been discussing, and I've been about pathways within which we can use technology to try and improve epilepsy care for patients, as you've mentioned, and I think this is an outcome the Epilepsy Research UK are interested in. Of course, at work we've started to have a lot of telephone consultations, and we're using video consults and things, and it may be that going forward, this is something that we need to look into as a way that people might not be exposed or fearful of the risk of coming to hospital may well be able to have consults, and particularly relevant to epilepsy, where often you know the patients, you know them very well, and we know you when you're unwell, and we know you when you're well. And I think this is something we hopefully can try and implement in future, really, around this, to try and improve things, because as you say, it's a difficult time with corona and access to hospitals at present.
Of course, thank you. And a very quick final question from Joe Bryce on Zoom. Beyond the presentation session, was there interest from the cross-party group on epilepsy in Scotland to continue looking at this in more detail?
Yeah, so the outcomes that they've had from that is, well, we're waiting to first publish our results to see exactly what areas are going to be the highest impact, and that will come particularly from the case control aspect. And then particularly through the charities that we're involved, we'll be looking to disseminate that message, and we'll be looking to feed back to the cross-party groups as well, because this is a regular meeting that happens. So it might be that we're invited back to talk through exactly which outcomes we may be able to implement based on the study project. So I remain hopeful about that, and my hope is that we will be able to implement some of these changes as with anything as the scientific information starts to underline which evidence pathway is best to be followed.
Brilliant. Thank you so much, Gash.
Thank you.
Yeah, thank you from us at Epilepsy Research UK for your work, both in research and on the clinical front. And last, but certainly not least, I'm really delighted to welcome Umesh, who's a clinical research fellow based at UCL at the Institute of Neurology, who's going to talk about his work around epilepsy and diagnosis. So hand over to you. You've got a very interesting title to your talk. I'm looking forward to it.
So as mentioned, my name is Umesh, and I'm working in UCL at London. And first of all, I would really like to thank Epilepsy Research UK for their generous funding and for inviting me to talk today, and for you who are listening, for contributing and fundraising to further my work and the work of those speaking today. And I would also like to say we don't do research in isolation, and I would also like to thank the amazing physicists who work here at UCL and at Nottingham for developing this method. So why am I talking about submarine technology? Well, it may surprise you, but a number of people are interested in looking at how magnetic fields and the Earth's magnetic field changes. One particularly interested group are the military, to look at submarine detection, others in terms of geophysical survey, and now in clinical medicine. So one key investigation in the diagnosis of epilepsy is the electroencephalogram, or the EEG. And I'm sure a number of you listening today have had one of these tests done. And essentially what it does is it looks at the movement of electrical currents across the brain. And sometimes there are some telltale signs or changes in the EEG which can help diagnose epilepsy. However, there are some limitations associated with EEG that include motion of the patient when they're being recorded, as well as muscle artifact like chewing. An alternative method to look at electrical currents is to look at how they affect the local magnetic field around the brain, and that's what magnetoencephalography, or MEG, does. And here is a picture of a MEG scanner. Now, MEG has been around for a number of years and is actually being used in a number of specific cases of epilepsy where EEG has not been conclusive. But looking at this picture, you can see there are some very significant limitations with this. It's cumbersome, it's expensive, there are only a few scanners in the country. And also, as you can see, this person is head fixed within the scanner and has to keep still. So what we've been doing here at UCL and with Nottingham, I apologize for the picture, is to use state-of-the-art sensors called optically pumped magnetometers, or OPMs. This is an example of the first generation of ones we use. And now, more recently, we've adapted to use these sensors, which are the size of Lego bricks, essentially. And they have two sort of key advantages over the traditional MEG system. The first is they work at room temperature. And that means, secondly, they can be placed directly on the scalp, a bit like EEG, but not using glue or any of the adhesive that EEG uses. Moreover, we can put these sensors in the region, the brain region that we're interested in and where we think that the epilepsy is coming from. Now, looking at this technology, we've spent a portion of the money that ERUK have given to make these helmets. And they're actually 3D scanned helmets that are specific to the person. So they're based on the MRI scan that the person has had. So should be very close to the contours of the scalp and of the brain, hopefully. And so this was the first ever world recorded and published functional imaging of a patient with epilepsy using OPM MEG. And as you can see on the left-hand side is a typical EEG, and on the right-hand side are changes in electrical activity that you would associate with epilepsy. So these are called spikes, and this is called a sharp and slow wave. And here again, it's a sharp wave. These are little changes in the electrical activity that suggest that they may be coming from an epileptogenic part of the brain. And then moreover, we can use this information and the MRI and put the data together to see the region of the brain that we think is probably related to where the epilepsy is coming from. So, as I said, this is very much in development, and we've recorded from a couple of patients. More recently, we've been able to use a motion tracker so that we can look at how the person moves their head within the scanner and then regress or take out that motion from the recording that we have made to make it even more sensitive. And our aim really is to translate MEG into a long-term recording strategy. So some of you may have had EEG telemetry over a number of days, but using traditional MEG, that's not possible. And hopefully we can make that a reality using OPM MEG. And that's no more important than in children. With two young ones myself, I know that it's very hard to keep them still for 2 minutes, let alone for hours on end when we're recording. And so the idea is to translate MEG using these new OPM sensors so that children can move freely within their environment and still be recording. So that's really it from me, and special thanks to a number of people who have helped and really guided with this project. Professor Matthew Walker, and also our MEG department here at UCL under Professor Gareth Barnes, and most importantly, those that have funded this work, including Epilepsy Research UK. I remember when I received this award, I got to meet those who specifically fundraised for this project, and they were driving classic cars around England to raise the money, which I thought was a fantastic endeavour, and I'm very grateful to them.
Thank you so much, Umesh. That was a great talk, and it's great to hear about a world first that ERUK has helped to happen. So we wish you all the best for taking this forward and hope it develops. Quiva.
Thanks, Umesh. A lot of people are amazed that we can apply submarine detection technology to epilepsy, and I think, as well as you've highlighted, this could be such a brilliant tool to use when there are young children there who can't sit still. So thank you for this. And you mentioned that you've had recordings from a couple of patients now. Are the next steps of this research to continue getting recordings from patients?
So patient involvement is incredibly important for this line of work. As I mentioned, it's very much in development, and actually having the feedback from patients who have had this type of recording when we made the first sort of helmets, where were they uncomfortable, how can we change that, how can we get to the aim of them being able to move around in their environment without feeling that they're actually being recorded from. And I think we are now, obviously it's been curtailed slightly with coronavirus, but hopefully we'll be able to recruit more patients to record from, gain more information from, in our aim to sort of making this a clinically available tool for hospitals and a cost-effective one as well.
Yeah, I think that would be fantastic to then see this rolled out to a number of hospitals. And then, so what about, how did you first get interested in epilepsy as a specialty?
So I think during my neurological training, I was with epilepsy itself. I was amazed to see that the breadth of people that were affected by epilepsy, from infants to those of the older generation, and sort of the wide range from genetic epilepsies to those caused by strokes, for example. And although epileptic medications are an amazing advance over the last 50, 60 years and have really changed the lives of a lot of people, it's still frustrating to know that a third of patients are refractory to these drugs. And I think that's what sort of drove my interest in trying to help that third of patients.
Thank you, Umesh. And we've had another brilliant question from Alistair on Zoom. Do you think the most exciting developments are likely to be based on new drugs in the future, or is it perhaps technology like wearable devices, or perhaps it's technology in relation to your own research?
So I think it's probably a combination of all three. There are new drugs that will be coming on the market, but usually they're adaptations of previous formulations. And as we see that with every new drug, they do usually come with the same profile that a number of patients would not respond to them. I think tailored therapy for individual patients will be something that I would hope for in the future, that it won't be just the same sort of stereotypic approach to treating patients, but actually it'll be a lot more patient-centered and specific to them. And that actually involves a number of the other aspects of epilepsy treatment, perhaps patients' genetics or their imaging, and the way that their brain is wired up, because all our brains are wired up differently, and actually being able to have sort of this sort of bespoke approach to therapy, which would be something I would hope we would see in sort of 10 to 15 years' time.
Thank you so much, Umesh. We're really looking forward to watching your project progress once research is back up and running. So thank you.
Thank you.
Brilliant. Well, thank you to our four speakers. We've somehow filled our hour in incredible time. And for those that have asked questions, some of our panelists are still typing away and trying to get back to you. But all that's left for me to do is to say thank you to everybody who spoke, and really to just highlight that, you know, the research that you've heard about today couldn't happen without two key things. And that's both the willingness of people with epilepsy to take part and contribute in research, and then secondly, the support of our generous donors and supporters to the charity that enable all of this type of work to happen. So, so thank you to anyone in those groups, and thank you for listening today. I encourage you to go and have a look at our website, take a look at the blogs. Everyone that you've heard from today has written a blog for us recently, except Ngawai, who we will get to write soon, I promise. And this is the second webinar we've held. We will promise another one after the summer, so look out for us on Facebook and Twitter, as we will promote one after the summer. But for now, let me just wish you all a good afternoon and a very pleasant summer holiday as it arrives. So thank you very much for listening.